That of SSM Health Ignition, not WBEV or Good Karma brand.
Ski here with Bert Callahan, Dr. Bert Callahan, with SSM Health. You're up in the Fond du Lac office, right?
Yeah, I work for Fond du Lac Regional Clinic, but based out of Waupun.
That's right. I always confuse the two.
Yeah, it's a wordy explanation, and then we also have an office here in Beaver Dam over on Corporate Drive, the SSM building out there.
I want to knock out some logistic stuff first. So we know you got the Beaver Dam office. You know you got the Waupun office. You got some team members there. We always like to give them a shout out. So we'll start with Luke and Joe. Yeah. One of them in Beaver Dam, the other one in Waupun.
Right. Luke Lencher is in Beaver Dam. He's people may know that name. He's his father was a chiropractor for many years, and two of his brothers are in the chiropractic business in Beaver Dam. And then Luke is a PA that works with me for 11 years now. Okay. Very experienced in orthopedics, and he works primarily out of the Beaver Dam office. Joe Heckenkamp is based in Waupun, and then they both alternate helping me in the operating room when we do surgery.
And then on top of that, we've got Eric Nelson there in Waupun and Andrea Smits in Waupun as well.
Right. Eric is an orthopedic surgeon like me and my colleague in Waupun, and his primary assistant then is Andrea Smits, who's a nurse practitioner from the Waupun area originally. So people up there certainly will know Andrea.
Awesome. Phone numbers, of course, Waupun area 920-324-6802. For Beaver Dam office, 920-887-6650. And safe bet they can transfer to the other one if you accidentally call the wrong one. Or at least they can give you the right number.
I think both numbers actually ring to the same phone.
Okay. Well, little inside news there for you.
Background on that.
I'm super excited because the last time you were on, we started talking a little bit about a subject, and we touched on it a little bit. And you decided to run with that, and I'm excited because I'm sitting here. If you're watching on Daily Dodge TV, you're going to be able to see this because we'll hold up some of these pieces. But you brought in some replacement parts for when people have to get surgery done, orthopedic surgery for like knee joints. And they're sitting right here on the desk next to me, and they're so much cooler and in some cases larger than I expected, but also smaller than I expected. Mm-hmm. I have so many questions. Let's start with the overview. I'm going to talk about knees because right now I'm thinking about knees because I'm 40. And I've got family members who are, older than me who have had knee problems, have had knee replacements. Knees are one of those joints that I think, in my opinion, and I could be very wrong, I feel like that's always what you hear people complaining about. The weather changes, feel it in my knee, going up and down stairs. Yeah, my knees can't do this anymore. I'd love to go walking or I'd love to go ride a motorcycle again, but I can't do it with my knees anymore. So I feel like this is a common thing. Am I wrong?
Not at all. No, knees are the most common joint that ends up getting joint replacement. It is the main joint that wears out as we age, and it's very, very common. It occupies most of my workday.
So when I think about knees and the type of joint that it is, it's essentially for our body, it's just like a hinge joint, right? Like it's not meant to overly twist. It's not meant to bend backwards, obviously. Correct. Or rotate. It's a hinge joint. Does that make it easier to work on? Less complicated, maybe?
No, I wouldn't say that.
Okay.
Because it is in simple terms, it's a hinge joint, but it's much more complex than that. And there is some movements, rotational movements, rolling, translational movements. I mean, it is more complex. When you're trying to recreate that with a knee replacement, you have to be concerned with the soft tissue, the ligaments, the tendons that are surrounded, and the tension and tightness of each, critically important for how long these things last and how they function.
Now, again, like I said, I'm excited because you brought in some pieces for us, and I'd like to kind of showcase these a little bit and talk about them a little bit because most of these are for knees, correct? Or are these all for knees?
They're all for knees.
Okay, because I'm seeing a piece that looks very flat. Is that for like connecting? For those of you who are not watching on video, you really should be. Okay, tell me about this piece you're holding up now.
So this piece and this piece, they're just two different versions for two different systems of basically the part that takes the place of the cartilage.
Okay.
So to just back up a little bit on knee replacement. The knee, it is a hinge joint, but I tell patients sometimes the problem with knee arthritis is that it's not so much a bone problem, it's a cartilage problem.
Okay.
And so each bone, and those that are hunters know this if you look in a joint, or even if you have a bucket of fried chicken and the leg, has that shiny white surface in it, that's cartilage. That's the way our bones look also. They should look that way.
Right.
When I see them, they don't look that way. But so that the bone has a cartilage covering on it on every side that touches. So in the knee, you have the femur, the thigh bone, you have the tibia, which is in the leg, the lower leg bone, and then you have the kneecap. And all of the surfaces that touch have that cartilage layer. And the problem that ends up being treated with knee replacement is that cartilage is wearing off. So it's just like a tire going bald. And so what we are doing in knee replacement is doing a new surface. So we're not cutting it off, 6 inches above and below the knee. We're really trimming about the thickness of these parts, not more than 1/4 of an inch of bone to put a new surface. And so we put a new surface on the end of the thigh bone, the femur,
Right.
and the top of the tibia. And then this piece that you mentioned snaps into that top piece and takes the place of the cartilage. So this is the tibial piece on the bottom, femoral piece on the top, and then in front is where the kneecap is. You have this tiny little button that it takes the place of the cartilage on the back of the kneecap. It sits in front.
Okay. And then so this is basically like when we think of the cartilage, it's a layer that's meant to help prevent like bone on bone rubbing, essentially, which that would cause obviously things to wear down and damage whatever.
Right. And the bone on bone term comes from when you develop arthritis, that cartilage is wearing off until the bone is exposed. And so when the bone is exposed, it hurts because cartilage does not have nerves in it.
Right.
So we can't, in the normal setting, we cannot feel them touching one another. But once the bone is exposed, there's lots of nerves in the bone, and so it hurts when they touch.
Okay.
So that's why it hurts when we break a bone. So once the bone is exposed, it'll get your attention.
Okay, that makes a lot of sense now that I'm thinking about it that way. So this is why you can't just like go in and, I hate to use this term, but sand and polish both parts of the bone surface and it's good to go. You need to have some sort of intermediary in there.
Correct. And one of the things that happens when the cartilage wears and people are developing arthritis, they develop bone spurs. The spurs are not the problem. And so it's, going in and kind of sanding off the arthritis, you can't do that because it's not too much of something, it's not enough. If you think of a bald tire again, you can't go sand the bald tire and make it better and put a tread on it, or you can't trim something off or remove something from a bald tire and make it better.
Right.
You need to add something. You need to add new tread.
Gotcha.
That's what we do with knee replacement.
Now, for a layman looking at the parts that you have in front of you, I'm thinking it looks like, oh, this is the same material my faucet's made out of, shiny chrome, stainless steel maybe, and what looks like plastic, or in some cases almost like a hard wax, it looks like.
It does look like that. It is it is an ultra high molecular weight polyethylene.
That sounds incredibly fancy.
You're right. It takes me a while to get all the words out, but it is plastic. I just refer to it as plastic. But it has been manufactured in such a way to prevent wear. But yeah, it's basically a very high density, very smooth, so to reduce friction plastic. And this one, which I don't know if the viewers can see, is more yellow than
I was going to say,
one.
it's got an off color to it.
And that's because it has vitamin E in it, which is supposed to give it better wear properties.
Interesting. I think a vitamin E is like a vitamin we take. I don't think a vitamin E is something you put into a material.
You put it in plastic in this configuration, it resists wear.
Now, any particular reason why they choose to go with a white color? Could they make it any color? Or is it because of the type of material? Like, maybe that's a dumb question to ask.
No, it's an interesting question. Historically, there was a version of plastic that had carbon in it that was black, but it failed early, and so when you would open up those knees, the inside of the knee looked a lot like our table here. It was just all black. So it's all my whole career. It's been white. It's just maybe the the way the plastic comes out without adding any pigmentation to it.
Now, my next potentially really dumb question. I see two different sizes here. Is this something where you just look at the person's knee and say, oh, you're a large, medium, or small? Or are these more custom fit?
Well, there are many sizes. So it depends some on the system that the surgeon uses. I use a system that has a dozen sizes of tibia, a dozen sizes, actually 24 sizes of femur, because it's a dozen sizes front to back, and then a standard and narrow width. And so, but we directly measure it at the time of surgery.
Okay.
You can't. Some people ask about, do you template that off the X-ray? And the issue with that is the magnification. When you do an X-ray, it depends on how far away you are from the patient. I mean, even millimeters make a difference on what the. So that's not a reliable.
It's like
way.
trying to measure the size of curtains you need for a window from a picture you take on your phone.
Yeah.
Okay.
Exactly. So you measure it directly at the time.
Now, I commented when you first set them down that I thought these look incredibly shiny. They're very chrome. I'm assuming that's on purpose.
Yes, especially on the femoral side, which is this piece. This is a cobalt chrome in most systems, and it's made to be very shiny because you want low friction. If you have friction, you have wear,
right? And
wear is the enemy. That's what makes these things wear out or loosen. Is you generate wear debris.
Now, does this mean you guys, when you're doing the surgery, do you have to inspect them ahead of time, make sure that there's no scratches or dings or nicks, like they haven't been dropped or something that would cause damage? Are you worried about that?
No, because they come sterilized in a package.
So you're not digging in a bin. I guess that makes sense now that I think about it and say
correct.
it.
Not digging in a bin.
Okay.
That's a good question.
So these ones aren't going to end up in somebody like next week or whatever. These are meant for example purposes.
Correct. These came out of somebody.
Oh.
But they are clean.
Interesting.
But they were in, and then I cannot remember the reason they had to come out, but they had to come out.
So there are reasons they have to come out. And actually, that it leads to another question I have. So my father-in-law, he had a bum knee. They had to go in and replace it. And they replaced it. Went through his typical follow-up care, the rehab, making sure everything works. And it ended up getting infected. Turns out he was allergic to something in the actual knee replacement that he didn't even know he was allergic to. Not something that you would typically discover, I guess, that you're allergic to necessarily. And so they did have to go in and remove it and replace it. Is that a common thing to have to do, or is it something where they can wear out over time? You have to replace them, it's like brakes in your car where they have a 30,000 mile.
There's about 30 minutes of answer in
okay.
in the questions you asked there, and so the short answer is it common? No.
Okay.
But I also should preface it by I'm genetically incapable of giving a short answer. So if I'm
lay it on me, I'll take it. Yeah.
The allergy issue is different than the infection issue. Although
okay.
if a person has one of them, it looks very similar in the way they feel: swelling, pain, that sort of
right.
thing. Allergy is primarily to nickel.
Okay.
So you typically have cobalt chrome, which usually has nickel with it, and then you have a titanium alloy. The femoral side is the cobalt chrome because titanium is too soft to be a bearing surface.
Okay.
So the titanium piece is covered by the plastic. But bone grows to titanium very effectively. Titanium's stiffness is very similar to bone, so that's a positive attribute when you're putting in artificial pieces.
Right.
So there are implants made that are nickel free, and it depends on the company, but I think there are certainly orthopedists, me included, who are moving to using those more routinely. In the system I use, they do not have the full complement of sizes, but I have a very low threshold to put in nickel-free implants. Certainly anybody who knows they have a metal allergy, they get nickel-free implants.
Right.
Anybody who has, some people just have a lot of allergies. There are patients who come in, they have 15 allergies, which is unfortunate for them because that's
right.
tough to go through life without being exposed to things. Those people will put in, even if they don't have metal on their list or nickel on their list, you don't want to take any chances.
Right.
So that's an unfortunate thing for your father-in-law to go through that.
Right. Yeah, nobody wants to have to go through knee surgery more than once.
Correct. Right.
But it can happen.
It can happen, absolutely. And there are other, infection is the one that I worry about the most because it's devastating. I mean, there are others that are, I mean, that one is certainly I want to avoid. It's not as common. Infection is a potential every single time you have an operation of any type.
Right.
But it's particularly difficult or challenging when you put in a big implant, because infection in joint replacement can attach to the metal, and then you can't get rid of the infection until you take the metal out. So it is a life-changing, you're never going to be the same kind of situation for most cases. And so there are a lot of steps that we go through and things we have patients go through to try to help reduce the risk of infection. Huge issue. I think about it every single day, things that we can do to prevent that from happening, and
including not pulling the parts out of a bin and working with sterilized parts.
Yep, that's right on the list for sure. Right.
Yeah, that makes sense. So we know this is a common thing. This kind of surgery is done. I see in your notes here, approximately 800,000 knee replacements done in the U.S. every year.
Right.
Anticipating 2 to 3 million by 2030.
Right.
Are we just doing stuff that's harder on our knees? Like, what are we doing wrong?
Well, part of it is I'm at the end of the baby boomer generation.
Right.
And that generation is moving into the age where you get arthritis. That's certainly a big contributor.
Right.
We're heavier as a population than we used to be. That contributes to it. I think the technology has gotten better, and so I think we're turning to that at a younger age because it lasts well. And so I think those factors together are contributing to this enormous increase in numbers. And it's a challenge for the health system because the total number of orthopedic surgeons is kind of slowly declining. It's really not increasing to keep pace with it. But there's a lot of logistics involved in doing that, because for us, if I do 150 knee replacements in Waupun in a year, if I double that, how would I do 300? You have to have staff for it. You have to have operating room time. You have to have bed space in the hospital. I mean, there's a lot of logistics to doing that. But the system as a whole has to know how to deal with that. Plus, how are we going to pay for it?
Right.
Our country is already buried under medical costs. I mean, and I'm sure there are people much smarter than me that are thinking about all those issues too. But just on a local level, I talked at my local hospital about, okay, we need to be able to have some capacity to do more numbers just because the people are going to be there. And if we can't, they will get them done. They'll just go elsewhere.
That's crazy. Now, how has the process changed? You've been doing this for a while. Are things getting better with the process? Does it go quicker? Is recovery faster now? Are the materials helping? Because knee replacements. I thought I saw a note on here somewhere where you had wrote down like when the first knee replacement was done.
Yes, so that's historically it is. The short answer is this: the overall operation is the same in the fact you have a piece on the kneecap, piece on the tibia, piece on the femur. Those three parts. That's always been a resurfacing operation. It's not been more drastic than that. But virtually every other aspect of has changed and improved, from the materials, from the technique of doing the surgery, from the technology that's used to do them. All of that has improved. The preoperative preparation, the postoperative care, the rehab, all of that has changed significantly for the better.
Now, looking at your notes here, I see a little bit of history for it. 1951, I see the words acrylic listed. I see early 1860s. Holy cow, 1860s. German surgeon implanted a hinge joint made of iron. I imagine that didn't go well.
Yes, and when I was reading that, it just brings up a whole lot of questions, like, well, what kind of anesthesia did he have? Did he make that in the, he had the blacksmith make that in the, was it sterile? That was well before any antibiotics. I'm sure it did not go well. And that's, if you look at the history of joint replacement in general, whether it's the hip, the shoulder, the knee, that's been attempted with various materials for years, centuries. I mean, it goes back in the 1800s. They were doing that, and so initially iron, then acrylic, but all of that didn't perform well, and it wasn't until the more modern materials and manufacturing processes came about that started to see some success with it.
Right, like the titanium, obviously, as a material. On here you have 1958 cobalt chrome coming onto the scene, but then it looks like it was 10 years after that before the first knee replacement was actually done in the U.S.
Yes, and part of the problem of giving exact is the type that's resembling what we have today.
Okay.
Because it initially, in that same time frame, people were putting in some centers basically half of this, putting a half on each side.
Okay, instead of one complete unit.
One complete. But in this kind of basic configuration, the late 60s are a good time estimate. And for hip replacement, it was the early 60s. So it's kind of, and shoulder replacement in the early 70s. So in that time period, while the whole country was consumed with Vietnam, the orthopedics was moving forward with joint replacement or getting it started.
Now, when I think about knee replacements, I'm also thinking about who's more susceptible to this. Obviously, people with arthritis or who develop arthritis in their joints, people who maybe have jobs that they do that are really hard on the knees, stuff like that. Maybe people who are athletes put a lot of work in on their knees. Is it proportionate male to female? Is it disproportionate male to female?
It's a little bit higher female to male.
Interesting.
It's multifactorial. So there's genetics. I tell people sometimes, we turn into our parents eventually for better or for
whether
worse.
we want to or not.
I like telling my kids that just to freak them out a little bit. There's genetics of prior injury. So people that are athletes in high school, early adulthood, and have an injury that certainly sets them on the road to an earlier development of arthritis. There are some people that's their genetics to wear out, and some it's not exactly related to activity, because if you look at people that are marathon runners, who obviously aren't built like us,
right?
They do not have a higher rate of arthritis, even though they have a higher, obviously put a lot of miles on their knees. So it's definitely there's a lot of factors involved, not all of them that we can control.
Interesting. I guess I hadn't really thought about that. So we talked about you saying these units had come out of somebody. Was that because they weren't working anymore? Did they have to get a new replacement? I know you said you know the exact reason, but is it common to have to get them replaced?
No. To get them redone?
Yeah.
No, not common at all. That's most of the modern. Because a lot of people ask, how long will these last?
Right.
And the things that make you have to redo them, one is just it wears out over time. That's the number that is given for that is 90% of them still should be functioning after 20 years.
Okay.
I'll come back to that because there's a more complicated answer to that. The things that, aside from that make you have to redo them are infection, some allergy reaction,
right.
And then there's sometimes the people develop what's called mid-flexion instability, which is a subtle thing that happens where the tissue, as people heal, loosens, and it can loosen to a point where it's looser than the knee likes, and people don't like the way it feels. It's also a subtle thing to identify, but that's part of the challenge of when you put them in is getting all that other tissue balanced right. And I was referencing that earlier. Probably the best thing we can do as surgeons that affects the longevity of it is getting it balanced right. It's like your tires again. You get your new tires, you need a front end alignment to make sure that they're wearing equally. Same
right.
thing. If it's a little bit off, too tight on one side versus the other, they may wear asymmetrically, and one side may wear out faster.
Right.
And so that's a challenge, because the knees, when you go into them, they're not a normal knee. That soft tissues are tighter than normal, and so you're trying to restore not just, really it's just basic carpentry to to put these things on, but it's getting all of the things, the soft tissue balance, which is individualized. Is getting that right is the challenge technically.
So I have two questions for you related to what you just said. If you do have to go in, let's say somebody's had it in, we'll say they make it 22, 23 years, and they're like, okay, it's definitely having issues again. I need to have something done. Is it as simple potentially as just going in and replacing that cartilage, like amalgamation, that replacement for the cartilage, and the material, like metal parts, can stay?
That would make sense, wouldn't it?
It would make sense.
No, it doesn't work that way.
Of course not.
Of course not.
Of course
The
not.
problem is, by the time this stuff is, or while this is wearing out, the patient doesn't have any pain.
Right.
They only begin to have pain when the pieces themselves begin to loosen from the bone.
Okay.
And once you get to that point, it's too late to just replace this. And that has been looked at as doing revisions where you just replace this and it doesn't work.
Right.
So you can't, it seems intuitively that you should be able to do that, but it just doesn't work that way in the human body.
Interesting.
Because these things, when you're wearing them, they're generating microscopic wear particles of plastic.
Right.
So when you're driving down the road, you're generating microscopic or rubber particles, right? And you just leave them on the road as you're driving.
Right.
In the knee, it doesn't work that way. Those microscopic particles are accumulating in the knee. They're microscopic. You can't see them. But the body is trying to get rid of them, but it has no mechanism for trying to get rid of them. So the cells are taking them up, trying to get rid of them, and over time, these cells that do that in our bodies, it open up, and all of their digestive enzymes come out, and it causes the bone to slowly resorb from the implant and loosen. And that process takes years and years and years to do it. But that's the problem. That the plastic is what the wear issue is. It's not the metal that's wearing out. It's the plastic that wears out.
So really, we just need to find a better replacement for the plastic.
Well, which in my career, that's probably one of the top technology improvements that has been made. And part of it is this vitamin E. Right. The other thing, which you really can't tell, is the way it was. These plastic structures are cross-linked, it's called, through heating. That is shown to be better wear. And so when I was a young orthopedist, there was a lot of conversation about wear, and I would see these graphs because they can simulate 20, 30, 40, 50 years of wear in the lab.
Right.
I've seen it, and they have these little machines that are, the knees are working, and they can count the particles generated. Wow. And so I would see these graphs of time versus number of particles, just a straight linear line up. And with the newer plastics as it came out, you'd start seeing these graphs. Instead of this way, it was this way. And so numerically, this newer plastic generates fewer particles, which it makes sense that they would wear out more slowly.
Right.
And that is what we're seeing. But the problem is you need to have it in people for a long period of time.
Right.
And that's the dilemma. If you say you get a 5-year follow-up and everything's functioning well, I would say if I'm reading an article, I'll say that's meaningless to me. 5 years is no time, and I need to tell me what your 20-year, your 25-year, your 30-year data is. Right. And that's the challenge. It's like if say a reputable company, tire company, said I have a 500,000 mile tire. Because of what I do for a living, I would say, okay, who's run at 500,000 miles?
Right.
But if they said, well, nobody, but we've simulated in the lab and it showing wear, and if it was a reputable company, I'd say, okay, maybe that's worth it. And that's the setting. You have these big companies that are saying this is generating hardly any particles over time. I think it makes sense that it is going to wear better over time. But the proof is going to be in the after I'm done when you get 30-year data.
Now, the other thing you had said was you kind of threw it out there casually, like, oh, this is basic woodworking. So does that mean you're there with your, like I think we joked a little before the show, you got your Milwaukee drill set, and you open up the bid box and pull out your sterile bit and drill some holes and, put in some number 10 screws?
Well, kind of. When I've operated on people that do that for a living, they see that we have a lot more in common. I just work with a different medium than they work with. It very much. I mean, the principles of carpentry definitely translate to what we're doing in orthopedics in a lot of settings.
So talk to me about recovery time right now. If somebody comes in and sees you and you evaluate and decide knee replacement is the way to go.
Right.
One, how long are they waiting to get it done? And two, what are they looking like for recovery process and duration?
Yeah, great questions. So as far as waiting time, that really varies depending on where you go. I mean, but the problem is this number of people that need it. And so right now I have very few appointments before 2025 because I have a certain amount of operating time. I can only do a certain amount of cases per day because of the time and the equipment involved. Mm-hmm. But that varies by location and surgeon, certainly. It's never been that long. It's just been, I've tried to keep it for most of my career under 6 weeks, but it just in the last 6 months has kind of just gone to where it's now we're months out. But, more significantly is the work situation because a lot of people are still working.
Right.
And so I think you may get different answers from different surgeons, but I would say, it takes longer than most people expect to get where they want. I think it is harder than most people expect to get where they want. I recommend people to not plan to return to work for 3 months afterwards. I recommend you don't plan any significant activities for 3 months. Like one of my patients, don't fly to Hawaii 2 weeks after the surgery, as nice as that'll be to convalesce.
Right.
Really bad idea.
Maybe just don't. Right.
But it's the reason and most people are, and it depends, of course, what they do for a living. Mm-hmm. So, if you're working on a line at a factory, definitely tell them 3 months. Because I just don't want people, it's hard enough to go through it. I don't want people to be sitting there and thinking, oh my gosh, I've got to go to work next week and I'm totally not ready. And just add that stress on top of the whole stress of doing the operation and going through it. Right. Don't move into a new house. Don't take a long vacation. I mean, really commit that time to your knee. You're going to do your rehab very diligently. You're going to work really hard on it. Because you will, and people will get better over 12 to 18 months. I mean, right. They're probably, you get to a year, certainly 18 months, you have what you're going to have there.
Right.
But don't short that first 3 months.
We're almost out of time here, so I do have one last really dumb question, and I only ask this because I think about my wife, who she's had some knee issues most of her life. If she ends up coming in at some point in time and they say, yep, you need to do a replacement, I know the first question out of her mouth is, hey, while you're in there, can you somehow make me 2 inches taller? Is this something where people come out and they go, oh, I actually am taller because the extra equipment that's in there? Is that not a thing? Don't even try asking.
I love that question. But if you realize if I make one side longer, you're going to walk in a circle.
I guess that's a good point.
But in all seriousness, with knee replacement, you do not add much length. Other than somebody who has a really big deformity one way or the other and you straighten them, maybe you get a little length.
Okay.
But if you picture the knees here, right, and the ligaments around it, you're working within the ligaments. So if you try to make it longer, it's going to get too tight. The soft tissue is going to get too tight. Okay. You can affect length a lot more on a hip replacement than a knee because it's just a different setup. But so in a knee replacement, no, you're not going to change. You're just going to make the legs straighter.
So, babe, if you're listening at home, wait for a double hip replacement before you add any inches. Got it. That is good to know. We could probably go on and talk about this more for quite a while, and I think we'll have to continue this conversation at some point. But I do know my producers up in the studio are eventually going to start throwing stuff down here if we don't make our way out of the show.
Sounds good.
Before we do, though, I want to remind everybody again, I've been talking with Dr. Burt Callahan from SSM Health up in Waupun. Phone numbers again, secretly routed to the same location, but for Waupun, 920-324-6802, for Beaver Dam, 920-887-6650. Of course, We never hope people have to go through surgery of any type. But if they are having, any orthopedic needs whatsoever, they really should be reaching out to you guys, because it's better to reach out sooner than later, and better to get it looked at before this is the only option.
This is a last step.
Right.
I mean, there are a lot of non-operative options, and all of me, Eric, Luke, Joe, Andrea, all of us have a lot of orthopedic experience and can discuss how to keep you away from this as long as possible.
Right, and that's definitely the goal, I think,
Right,
is from
for
what
sure.
it sounds like. I want to thank you again for taking the time to come on. I want to thank you for bringing in some really cool visual aids. I'm totally going to be looking these over after the show and getting a close-up look at all of them, because that's just super, super cool. And look forward to having you on again soon.
I appreciate it. Thank you, Justin.
Thank you. The proceeding was a paid program. The advice and opinions expressed during the program are strictly that of SSM Health, not Good Karma Brands or WBEV.